All right, hi everybody. We are going to talk about chapter 3 here, which covers the all hazards approach. We've talked a little bit about this already, but this will go into detail to help us understand some of the systematic approach to doing this. So, emergency response work is obviously very broad, just like public health. And so it's crucial that we analyze what each partner in the space needs to do and what their capabilities are. So basically, what do we need? What do we need to get done, and who has the ability and resources to do it? So, what is an emergency preparedness system? An emergency preparedness system includes all of the institutions involved in preparing for and responding to hazardous events for a defined population, along with the relationships that allow those institutions to work together. These systems operate across multiple geographic levels, starting locally at the city or county level and extending to regional, state, territorial, national, and even international scales. Participants span across many sectors, including public health and emergency management agencies, healthcare providers like local doctors and hospitals, public safety like local law enforcement, social services, businesses, utilities like water and power, and faith-based organizations, each contributing distinct roles that together support a coordinated emergency response. So this slide here sort of gives you a general idea of what a emergency preparedness system is shaped like. We can see that down at the bottom there, we have health departments at the local level connecting to emergency management agencies, sort of in a horizontal fashion. We work um, across the agencies, getting to know each other and what those different roles might be. And then within the health department, for example, we also connect vertically to um, the state health departments. In this case, we're talking about California, how Riverside County, for example, where I work, might connect directly to the the California Department of Public Health. And then our counterparts who work in the Emergency Management Department, um, they connect directly, well, vertically connect to the state organization responsible for uh, emergency management, which would be the California Office of Emergency Services. And then we have these different levels, obviously, federal level, state governments, local governments, connected in that vertical fashion. FEMA is the lead national agency for preparedness, with public health specific emergencies being run by two divisions of the federal departments called the um, Health and Human Services, the Department of Health and Human Services, or HHS. So HHS, underneath that, there's the Centers for Disease Control, or CDC, and the Assistant Secretary of Preparedness and Response, also known as ASPR. So those two agencies underneath the federal umbrella of emergency preparedness. They work together. Federal agencies rely heavily on state and local governments to do the actual implementation work of preparedness and response. The federal agencies provide funding, technical support, and data. They have tools that are available to the state and local governments to help them do their work, and especially with like risk assessments, which we'll talk about later. State and local governments have broad powers to regulate businesses and behaviors, like we saw during recent disasters, where the local government was responsible for restricting public gatherings to help protect people from exposure to infectious disease outbreaks like COVID, and requiring protections like face masks. So we're sort of trying to regulate people's behavior in public, to help protect the community. So public health has its own specific emergency support functions within FEMA's list of 15 functions. So it's a way of organizing the resources of the government to support specific response activities. So public health is responsible for one of these um, support functions. It's actually ESF 8. So there's also 32 capabilities that are identified as part of FEMA's national preparedness goal. One of these capabilities focuses specifically on the implementation of public health, healthcare, and emergency medical services. Capabilities define what the system should be able to do and helps setting those expectations. So here's another visual overview of how the federal agencies define and distribute the roles and responsibilities of emergency preparedness and response. On this slide, we are providing a little bit more detail about how the federal government, through ASPR's National Health Security Strategy, how do we divide up the health protection activities across numerous federal agencies, including CDC, Medicare and Medicaid, National Institutes of Health, the Veterans of Health Administration, the VA, Substance Abuse and Mental Health Services Administration, or SAMHSA, the U.S. Department of Defense, which I believe is now the Department of War, the Environmental Protection Agency, the USDA. The strategy developed by ASPR also stipulates that healthcare providers, like your local physician, must carry out certain activities as part of their participation with federal Medicaid and Medicare programs. So basically, if these doctors, hospitals want to get reimbursed, they have to play the game with this strategy and figure out what they need to do. They have certain capabilities and requirements that doctors and hospitals have to be able to comply with during an emergency and preparing for an emergency in order to get funding properly from the federal government. So that's called the Centers for Medicare and Medicaid Services Emergency Preparedness Rule. That's what they have to follow. So hospitals and other community partners participate as well in the Federal Hospital Preparedness Program, the HPP. They receive funding and technical assistance to support a national network of regional healthcare coalitions, and they focus on emergency preparedness and response. So all these hospitals basically are in these collaboratives, these coalitions, to help work together so that they all, hospitals obviously are very interconnected. Patients are not specifically assigned to any particular hospital. So during an emergency, hospitals have to help coordinate the care of patients from all over, maybe shifting jurisdictions. They have to coordinate. So the CDC, um, Public Health Emergency Preparedness and Response, or PEPR, the CDC's PEPR framework defines a total of 15 capabilities which fall within two tiers. Tier one capabilities function as foundational elements for public health agencies, whereas tier two capabilities build on those and extend the tier one capabilities to external partners who collaborate with public health agencies. So there's all these different capabilities that the system is trying to make sure that all the different players in the system have the ability to do in an emergency. So these capabilities are crucial for these different agencies to demonstrate. So we're talking about capabilities in this case, like community resilience, incident management, and surveillance. So here we're breaking down all of the 15 capabilities from the CDC's PEPPER program. Some of these are more geared towards public health partners like medical surge, that would be like hospitals, which deals with how facilities can deal with massive waves of patients hitting the system. So if there's an outbreak or a major natural disaster like a hurricane or something like that, they're going to have potentially a lot of patients flooding the system, the healthcare system, that would typically overwhelm. There's not going to be enough staff or beds or resources. So how do hospitals plan for stuff like that? How do they develop medical surge plans and techniques to bring in more staff as needed, expand their waiting rooms and stuff like that? So public health departments, we'd be more directly involved with lab testing capabilities, um, surveillance activities, being able to understand what the disease trends are happening in the community and doing epidemiological investigations. So who's been potentially infecting others? How do we do those contact tracing investigations? Those are capabilities that would be unique to the health department. So everybody has a different capability across the partner network. Federal agencies operate again on the all hazards approach. So preparedness capabilities are designed to address a wide range of potential hazardous events. So all emergency planning systems struggle to coordinate the work across sectors. It's not easy to do. They have, because all these different sectors, partners, if you will, they have different interests, concerns, and resources. Obviously, the education sector is going to be focused on a different set of priorities than the law enforcement sector. So schools, for example, might, they recognize the need to prepare for emergencies, and they do a great job at very specific emergencies, but they also have a lot of competing priorities. They're trying to, on a daily basis, deal with a lot of different situations, and preparedness may not be at the top of their list for a flood or a hurricane. So it can be difficult to get their staff, who are very busy on a daily basis with students, to come participate in a disaster drill, for example, Their priorities are just more focused on the day-to-day operations. Not unique to them, but just giving an example of how coordinating emergency planning is difficult. Many sectors would rather just let others do the work for them. So that's definitely a challenge. And this talks a little bit more about some of these challenges for doing emergency preparedness work. Agencies may be reluctant to invest in prevention and preparedness because they don't necessarily see the return on investment right away. You can invest, for example, in solar panels, maybe as a backup power source, but they're expensive up front, and you may not get your money back until years later. Some organizations in preparedness terms pay the bill, while other organizations get that immediate benefit. So that can cause a little bit of reluctance on behalf of some agencies to participate if they feel like they're being taken advantage of and partners are, start backing out. So um, we can talk about some of the backbone institutions, state and local state and local public health agencies often function as these, the spine or backbone of the emergency preparedness system because of their legal authorities. They have administrative capabilities that are relevant to emergency planning often, so they will often acquire funds through grant funding, so forth, and end up distributing that money through uh, sub grants or proposal RFPs, requests for proposals, where they will give out money to community partners who can do the work that needs to be done. Um, some governments create independent governing boards to help them oversee emergency preparedness work. These can function pretty well if they include a broad representation of relevant sectors, areas of expertise, and community members directly, especially including historically underrepresented and marginalized communities. We need to get those diverse ideas, viewpoints, experience, background to the table to help us address the preparedness activities properly. So basically, the heart of preparedness is communication and information flow. From alert notifications, like those alerts you might get on your phone, um, to releasing information to the public through those type of systems. That all requires investment. It requires modern data systems that can help us monitor health trends and environmental threats like storms and earthquakes. All that requires a lot of information data gathering and the ability to share that data after it's analyzed. COVID is one example, again, highlighted the need for a massive overhaul in health data systems. We were overwhelmed very quickly. Some of the antiquated data systems we were using just were not built to handle the exchange of millions and millions of records like lab results. So the old systems collapsed. We required, thankfully, there was an investment of new federal money into these programs. Most federal and state grants also have evaluation components built in so that we can help track progress on capabilities, measuring performance to make sure that the work we're doing in preparedness is headed in the right direction. So, how do we assess the strengths and vulnerabilities of the preparedness system? There's a lot of different ways to do that, but one way was developed to create the National Health Security Preparedness Index. And what that does is developed by the CDC and in collaboration with academic institutions to help track progress and preparedness, meeting those goals for preparedness objectives across many sectors. It uses the index they created, uses hundreds of measures from more than 60 data sources. The index aligns with CDC's PEPPER capabilities. We've talked about these earlier, and the index provides an assessment of all 50 states, all the way down to the county level. So it's a really well designed instrument to see and track progress meeting these preparedness capabilities. And preparedness has definitely improved. The level of preparedness, as measured by some of these tools like this index, we can see that things have gotten better significantly, especially since they started measuring in 2013. This book doesn't have, it's published a couple years ago, doesn't have some of the newer data, but I expect that some, some progress is continuing to be made. There's much more work to do to bring the scores up. Significant improvements, according to this index, have been seen, especially in surveillance work, where we're tracking data across the community level. Community planning as well has improved quite a bit, involving um, community members into the preparedness process. It's kind of a newer philosophy, so there's been some good progress there. And then in the general area of incident management, which you guys are going to learn, through these FEMA courses that you're taking and the rest of the book, um, how do we systematically approach how incidents are managed? How do we, there's sort of a formula system to doing it well. Um, and that has improved quite a bit, as well as environmental and occupational health metrics. The highest levels of preparedness occurred in the incident and information management domain, as I mentioned, indicating that our ability to implement standardized processes and protocols in managing acute phases of emergency events has really improved. A lot of that is based on lessons learned from major disasters like Katrina and um, so forth. The national preparedness trends show the largest gains in community planning and engagement overall. Between 2013 and 17, preparedness in this area, as measured by the index, increased by nearly 20%. This reflects stronger relationships among government agencies and CBOs, community-based organizations. These partnerships are critical for resilience and faster recovery after disasters. This domain was the nation's weakest area in 2013, but it improved more than any other. On the other hand, healthcare delivery remains one of the weakest domains for preparedness. That's a little surprising, I think, but while there have been modest improvements over time, national readiness remains limited, with ongoing challenges such as healthcare workforce shortages, longer EMS response times, limited hospital isolation capacity, staffing and infection control issues in nursing homes. And that was definitely a big deal during COVID, obviously, because the older population was heavily at risk for some of the adverse outcomes of COVID, and there was major issues with separating infected people so that they don't infect others, spreading illnesses like that. That's a major area that needs to be improved. Mental health provider shortages, it's a major issue as well. So these gaps definitely highlight the persistent vulnerabilities in the nation's emergency response capacity. And this graphic here shows those trends. The actual progress of the index is shown in the solid blue line there over 2013 through 2021. And then the dotted line shows, a dotted blue line shows progress, uh, projected progress on this index. And now this requires a lot of assumptions about resources in particular. Are we going to have the resources needed over these next decade or so to continue that progress, or is it going to be like a lot of times within public health where we have some success and then funding is dramatically cut and we end up reversing years of progress? So it remains to be seen. And this is another example here, a visual that shows the progress on the different domains over time. A lot of this was already mentioned in previous slides, but this gives you a visual of the scores in relationship to each other. You can see the dramatic increase in engagement scores, community engagement there, in that middle area with the purple line it is, I think. Yeah, it's purple. So you can see how quickly that particular area increased in improvement and then sort of plateaued. But there's more work to be done on all of these measures, and we'll continue to do that as a community together. So here's another visual. We're looking in this case at preparedness levels between 2019 and 2020. Overall, preparedness levels improved in 29 states, while preparedness declined in 7, and remained relatively unchanged in 15 states. And a total of 10 states had health security levels that fell significantly below the national average. So you can see there's quite a bit of disparity across the country in terms of how ready, at least according to these capabilities index scores, who's really ready for a national for an emergency. I was a little surprised, to be honest, by California scores being uh, um, qualified as one of on the lower end of the preparedness scale. I think we do a pretty good job here, but I guess the scores haven't really reflected that. And this is another example here. This map shows preparedness scores by county level. So all the way down to that real granular level, looking at which counties, for example, you can see the scores there, and um, across the nation where we're seeing the darker blue color there is more prepared, so to speak, in terms of these scores that they're achieving. The lighter colors, the lighter blue, all the way down to white, is the least prepared. Um, In general, preparedness levels in rural areas, like out of the cities, counties that are considered more less urbanized, they have roughly more than 8% lower preparedness levels than urban areas. Counties with lower preparedness level showed significantly higher rates of social and health vulnerability among residents as well. So those things kind of go hand in hand, where we often see with preparedness that there are vulnerable populations living in those areas that are more likely to be hurt disproportionately by emergencies because they're already disenfranchised before the emergency. So counties with larger proportions of Black, Hispanic, Native American, Alaska Native residents showed significantly lower preparedness levels. These geographic patterns reveal persistent inequities in the nation's preparedness system. So, improving national preparedness will require greater investment in core public health infrastructure. That's stuff that I mentioned before, like improving the ability of our local laboratories and disease monitoring systems. That's a big part of public health infrastructure that needs to continue to have solid investment, as well as the workforce that's doing the work. We need money to do that. So, over the past decade, funding for the two primary federal preparedness programs, that Public Health Emergency Preparedness Program and the Hospital Preparedness Program, PEPPER and HPE, both of those have declined. Although we did see a big surge, I think this book is not updated completely to show some of the investment in some of those programs, but in general, we're about to lose all that money that we did get from COVID. So in the next few months here, for example, my health department is going to lose hundreds of millions of dollars. So it's going to be a major problem. Um, Recent estimates, at least according to the book, suggest an annual funding shortfall of about 5 billion. I would wager that it's much higher than that. This leaves many state and local health departments understaffed and operating with outdated or incomplete technology. Preparedness also depends on strong multi-sector networks and effective leadership across the country. Coalitions that bring together healthcare, public health, community partners have been shown to improve preparedness and population health over time. So basically, the better network you can build with partners, the more likely you are to be able to withstand an emergency when it happens and prepare better. So expanding participation in these networks is essential. These partnerships form the foundation of community preparedness as defined by the CDC. And finally, medical surge capacity is one of the critical challenges, as I mentioned before. Um, the National Health Security Preparedness Index, that index we've been discussing, has consistently highlighted limitations in the healthcare system and capacity during large-scale emergencies. Basically, our hospitals and healthcare systems are easily overwhelmed when we get too many sick people needing care. So these lessons from COVID-19, for example, underscore the need to test and adopt new approaches to managing surges of patients in demand in these times of demand and during future crises. So, summarizing things a bit, another major priority for strengthening national preparedness is expanding real-time data acquisition, integration, and analytic capacity. This is one thing that we have at the local level and all the way up to the federal level really made a lot of good progress on expanding our ability to look at data quicker, or get data and analyze it quicker. Preparedness efforts rely often on fragmented and cumbersome data surveillance systems, many of which are poorly connected to clinical data and medical IT infrastructure. This is definitely an area where we continue to need investment, and we've made a lot of gains, but there's a lot more work to do, especially getting access to, real-time data with electronic health records, potentially stuff like that. Addressing these gaps will require coordinated efforts across local, state, and federal levels to identify unmet data and analytical needs, to build exchange platforms and better support preparedness and response. At the same time, there's also a critical need to expand research and evaluation. The scientific evidence base remains limited on which system capabilities and practices are most effective at improving outcomes during and after emergencies. So what do we need to measure that shows what really works? We have to keep working on that. Increased investment in preparedness research, these evaluation systems is essential to guide system improvements, and using that in a way that's grounded in evidence rather than just making assumptions. All right, that's the end of our lecture. We will move on to chapter 4 in the next one. So thank you for your attention, and see you soon.